Okay. This whole issue of quantifying pain. Okay. How do we quantify pain? Well, it's impossible basically because pain. How do we know whether something's working? We like to put numbers on things. By the way, in case some of you probably recognize me, I'm the guy that runs a little house of horrors. And I work with Bill Alexander many, many years, and Dr. Schwartzman. So in this many years, I'm the guy that does a lot of the testing, pain testing. And let's jump right into it. Who knows who this is? You know her name? Anybody recognize her? Harriet Cole. She used to sit right out here, right in front of the library. That's Rufus Weaver, who used to be a pathologist here in Arnhem back at the turn of the century, the other century. And Harriet Cole was a living woman who really admired him and his work and donated her body to him when she died of tuberculosis. And he decided to do something very special that had never been done and hasn't been done since. He dissected her entire nervous system. It took him months. Only time it's been done is won an award at the World's Fair. Only time this has been done. Entire dissection of the nervous system intact. The reason I show this is that a lot of nerves, a whole lot of nerves. These are only part of these are. So the point is this: there's a lot of nerves, a lot of places where things can happen. That's the whole point of this. And she used to sit right out here by the library, but now she's over at Queen Lane, over at the med school. But really amazing, and just give you some idea. That's not including the brain, just letting you know how complex the nervous system is. Lots of connections. So, how much does it hurt? A lot. We like to put some kind of a number on it so we know if something's changing. How do we run statistics on things and tell whether something's efficacious? We can't put a number on it. So, you all heard this one, okay? On a scale of 0 to 10, 0 being no pain and 10 being the worst pain you can imagine, what is your pain level? How many people think that that's useful? Right. Nobody.
Especially because we can imagine pain
right.
more than anybody else.
Not just that, but what do you mean? What kind of pain? But that's the gold standard. And
what kind of pain? Which
routine kinds of pain, like the normal, nociceptive kind of pain that we're talking about, normal pain, that kind of works. It's totally subjective, and yes, with a given person, you can get some idea whether they feel better. But anyway, but that's the gold standard. And this is the other one, okay? This is the same thing, except instead of giving me a number, you draw a line somewhere, we can measure to the 15th decimal point. Same thing, 0, 10. All right, that is the state of pain quantification in most places, okay? You're probably sick of hearing that. How much you heard? The 0 to 10, right? Okay. So, I'll just throw this in there. Some of you who've been in clinical trials know that there's a trend to using some of this kind of stuff. So instead of just having you, when you come for a visit, write down or tell us, somebody's sending home with these, this has certain questions, you fill it out, online. And the advantage of why people do this now is to get some idea of when you inputted this information, so when, because we know that pain varies. It's organized, it's automatic transmission, and we get some idea whether somebody's being compliant. So if you can send home with one of these in the clinical trials, because we really want to get the information in a timely fashion, we know that it changes. This is something that some of you, I don't know if any of you were in the trial, ketamine, this is kind of something that we sometimes use in trial. It's an activity watch. You put it on and it measures activity by movement. You can also input a number from 0 to 10. And the point of this is, and this gets back and just so you know that we look at these things. This is a normal pattern. This is midnight to 6 a.m. And what do you see in a regular person? They're not moving much because they're asleep, right? They're asleep. Pretty normal sleep pattern over 2 weeks. What do you see here? Not much of a normal sleep pattern. Really screwed up. That's what you see in chronic pain. We know that that's a real problem. Okay. This is the ways we kind of find out about this kind of stuff. So sleep is extremely important. I'm just throwing it up there because these are just a couple exotic tools we use. But that should be pretty simple. Okay. But we decided we don't like that because it's useless. So, by the way, and actually studies have been done on showing just how useless it can be. Chronic pain, this was relatively recently, and we took 78 patients who had two or more distinct pains. You know what that's about. 69% said that when they were asked on the 0 to 10 scale after the fact that they rated their main pain and ignored the others. 69% rated whichever pain was worse at the time. 64% combined both their pains. 64 plus 69 plus 69 is not equal to 100. That means that there's no rhyme or reason. When they ask you 0 to 10, which pain are they talking about? The point is that people are starting to realize that maybe we got to be a little more inclusive or find out more about it. This is the gold standard when it's looked at critically, especially in chronic pain. Okay, and the chronic pain is what we're talking about, because if it's not chronic pain, you probably aren't any place where they're asking you this all the time. It went away. So, very quickly jumping through, because some of you have seen this, I'm just explaining why these exist. Way back, Melzak and back in '75 was the first to kind of approach this idea. So, okay, well, let's try and find lots of words. Like there aren't a whole lot of words to describe pain usually. Let's try to find as many words as we can to describe different aspects of pain, put them together in a questionnaire. And there's categories, and I'm not going to go into a lot of detail on this, but the point is, a little bit better than a 0 to 10, and they came up with essentially this. This is the original McGill pain questionnaire with things like flickering, quivering, pulsing, throbbing, beating, pounding. People got together, named the doctors, dedicated words, and decided what the hierarchical order of sensation would be. That shooting is worse than jumping, lancinating is worse than pricking, lacerating is worse than sharp. It's a step in the right direction. A whole bunch of these, you circle which one is appropriate for the given time you're asked for, and then there's a score. You can actually add this up and come up with a score, and that's the McGill pain score. And it's slightly better, but these categories might be arbitrary. Studies have been done looking at the different aspects and how they change, and once again, ain't perfect, a little bit better, but the problem is, once again, this is being made up by people who aren't really in pain, assuming what pain is. We come up with the words, because we know what we think pain is, therefore we're going to ask you to try and relate somehow, and that's going to be the take-home message here. So, but this is kind of, even as short as this is, people are saying that's kind of long and involved. All kinds of ways of scoring this, I mean, you name it. People get hold of something, they find all different ways, and lots of papers on the McGill pain questionnaire. Decided to make it a little bit shorter, so this came along. 15 categories here. Mild, moderate, severe. A little better, shorter. But that wasn't satisfactory either. So the final one that you'll probably see if you come here is this one, which is 22 categories from throbbing pain to numbness, and there's things like sickening. If you've been here, you've seen this. Yeah. It ain't perfect. But, and once again, from nothing to worse. Why do we give you this? In spite of the fact it's not perfect, it's better than a lot of things, and sometimes certain parts of pain in a given individual are worse than others. Splitting pain may be their worst aspect, that would be the 10, and other things wouldn't. This is how we start to distinguish your pain versus somebody else's pain in a very relatively quick form. And yes, your 10 involved with somebody else's 10 may not be meaningful, but your 10 versus your 5 after treatment is meaningful. That's what we're looking for, the change. We want to see how this changes. This is why it's important you do this, because we want to know what kinds of pain get better with the treatments, because then we know what targets to hit. That's why we do this. We know it's not perfect, but it's all we got right now, and it's a good, quick way to assess what, and once again, this is standard validated. We didn't make these up. That's why we do it. Okay? So, drop at that. Okay, so that's for pain that you're in ongoing pain. Okay? Non-provoked pain. Once again. And in the best kind of studies, they ask you specifically over the last week or whatever of what we're talking about, when and what, when we're asking those questionnaires. Then we get into this range, evoke pain. This is where some of you may recognize me and not like me. Evoke pain. Okay. In other words, hyper or hyposensitivity to a stimulus. We talked about that a little before. You've heard people talk about allodynia. You know what that is. Allodynia is pain to something that shouldn't be painful. It shouldn't hurt, but it hurts. Hyperalgesia, too much pain for something that's slightly painful. Hyperpathia, where it's a blunted response at first, but then an exaggerated response once you cross the threshold. You've heard all these terms. We know these terms. They tell us something about what's going on, the pathophysiology. That's why we ask them. So, how do we find it out? We've got to stimulate you somehow and cause some of this so we get some idea. And that's uncomfortable, of course, but I'm just wanting you to know that we do this for a reason. The big issue, okay, is hyper or hyposensitivity result from chronic pain, which it very well could. Central sensitization, you've heard all about this, talked about today. Could it possibly be predictive of chronic pain? Somebody, before they go to surgery, has thresholds that are out of the normal range because they may have some underlying hypersensitivity. Maybe that person should get a little bit more analgesic before surgery or different treatment. So that's why we do things like this. You all recognize these things. Okay, the standard pad, there's a little brush, von Frey fibers. All these are to give us a little bit better idea of when they say, well, somebody is touch sensitive. Well, what does that mean? You know, somebody touches you differently than somebody else. Well, if we use a standardized thing, then everybody should get the same answer from the stimulus standpoint. If we standardize the stimuli, the only variable is the response. If the stimuli and the response are variables, in other words, it depends on which doctor in which white coat is touching with what, there's a variable there. Some big like me, versus somebody else, big difference. So we try to standardize by using certain tools that give us a number. We push on the area with this thing, we can see how many kilograms per square centimeter. Well, somebody says that hurts. At a given rate, that way if I give it to a resident or somebody else, they should get the same answer. They push at the same rate, get the same thing, because they did the exact same stimulus. If I just tell them to push their thumb, it's going to it's going to be up in the air. You all probably seen it. Anybody recognize this? Who's seen this test? Who's seen this? Okay. You all know what this is. This is the, some of you do. This is the thermal testing system, okay? It's the QST test that some of you have been sent for. This thing gets hot or cold in controlled conditions. And why do we care so much about hot and cold? Why do we care about how you feel hot and cold? Well, it turns out, you've heard all about small fibers, small fiber neuropathy, everything else, okay? Two very important kinds of small fibers are the A delta fibers, which are not the smallest, and then the C fibers you've heard lots about. These guys are everywhere, okay? They happen to mediate your feeling of warm sensation and burning pain tend to be mediated through activation of C fiber systems. A delta, cool sensation, sharp pain. The first aspect of pain, the first ouch, is usually mediated via transmission through A delta fibers. So as you might imagine, it might be useful to know whether those systems are working normally or not normally. Are your A delta fibers and your C fibers normal or not, helping us rule out what may be wrong. And some of you may have seen this. This is the typical kind of test we run. Starting to sit at the temperature, drops when you feel it, you push a button, so this is when you first feel it. So you feel warming, these are normal. When does it get painful? Okay, and somewhere around here, plus or minus, is where most people would hit. Most people say, yeah, I get about 10 degrees centigrade, that hurts, I'll stop it. Heat pain, most of us get about 42 or so centigrade, 10 degrees, 11 degrees above, starting point at 32, but that's what starts to think. So we know what normal should kind of be in people. We've done this enough on enough people, and this has been done. So we know what normal sensory function with this kind of test is. Very relatively rapid. So, why do I show this? Because this is a paper that should be coming out soon. This is Schwartz from the Bill, looking at a bunch of CRPS patients. Doing this. This is part of our workup. The workup is done to help the doctor, especially Enrique, is there suspicion that there might be a small fiber neuropathy? Because we do this distally. I do distally at some proximal sites for thermal sensation. The gold standard now is the biopsy, where they actually take a piece of skin and look for the fibers. This is quicker, and I can do more sites, so we get some idea off the bat whether there may be evidence of altered sensation, meaning that it takes longer till you feel the normal sensation, and whether it becomes painful too soon. If it's here, that's a little too soon, a little too sensitive to cold. Why? That's what. And same with heat. Anyway, back to this. This is a year's worth of patients, and looking at just cold and heat pain. This is dropped from 0, 32. That means the thermometer's gone to 0 degrees centigrade. This is at maximum at 50. So you put them all together, you average it all together, and it doesn't look very different than normal. You average all these. Okay, this is 8 different sites that we look at. These are all the patients. Okay, but if you break them out based on some criteria I'm not going to go into, it turns out this appears to be 4 groups, 2 main groups. Group 1, okay, Group 4. This would be pretty normal for heat and cold pain. So this group of CRPS patients doesn't seem to have hypersensitivity to cold or hot at any of the distal sites. Meaning that they don't seem to have a whole lot of sensitization, because once again, we're not just looking at just the painful site, we're looking at all 4 extremities. Okay? Versus this group, which is half, extremely cold sensitive and extremely cold hot, cold and hot sensitive. Something different between these two groups. Once again, we've talked about, and Bill talked about this too, about splitting people into groups to figure out what's different and what treatments may work. So this is using something as simple as QST and telling whether there's a generalized hypersensitivity, which would indicate the possibility of central sensitization very quickly, or not. That's why we do it. That's why you go through this. That's why, to be honest, this really isn't very painful to control people. So if you had a real bad experience with this and very painful, it's because something's wrong, right? Sometimes people say for this, they don't realize this actually hurts a lot, but it shouldn't hurt. So if it's hurting a lot, something's wrong. The nerves. That's why we're trying to help. Okay. So, two more final things, just to throw this up here, because you've heard a lot about opiates and how bad they are, possibly. This is one particular study. I'm just throwing this up because this is using quantitative sensory testing, the same thing. It was standardized thermal stimulation, looking at hot pain, cold pain, and without going into a lot of detail, what they found out is that these are control patients, no pain, no opiates. These are pain patients in chronic pain with no opiates, and these are chronic pain patients with pain and taking opiates. Bottom line, cold hypersensitivity was much more cold hypersensitive, much more hot hypersensitive, much more thermosensitive than these guys. Okay? Some would argue, and in fact they even come up with a criteria for differential diagnosis of opioid-induced hyperalgesia based on QST. I don't know if I totally agree with that. The point is that the only difference between these people are opiates, and it's making a big difference in this. Okay? But you argue, okay, well, but these are different people. It's apples and oranges. You don't know, maybe the people that are taking opiates were in much more pain, etc. Final thing is that this one was a relatively recent study where this is in individuals who are being started on opiates. 1 month of opiates. Cold pressure test, put your hand in cold water, tell me when it starts to hurt, pull it out when you can't stand it anymore. Before they started taking opiates, 1 month. After, when it started to hurt, tolerance, when you can't stand it. All these lines are going this way. This is the same patients. This is a small study, hasn't been really done one more time. The point is, only difference in these patients were taking opiates from here to here. It had a significant effect on both cold pain threshold and cold pain tolerance. Even when they give them doses of essentially of a opiate compound, IV, to test them, because once again, this should be stopping pain. So if it's stopping pain, you would expect your cold and hot pain thresholds to increase because you don't feel the pain. It's doing exactly the opposite. It's making them more sensitive in the short term. That's the only reason I bring this up is because, you've heard lots about this, but in the short term it does. So once again, that they're contraindicated in chronic situations because they may be exacerbating some of the more troubling aspects. That's why we make a big deal about it. And so, final thing, things to think about. I talked about some scales. I went through this very quickly. Okay, are we asking the right questions? No, right? Anybody think we asking the right question when you went on these questionnaires? Nope. How many people said they knew when they first got RSD or CRPS that this was different than any other pain they've ever felt? You knew something was different, right? Almost all of you. You knew this was not nothing you ever felt before, right? So, if that's the case, what words would you describe it? Because that's what I want you to help me with. I want you to help me with this. That's my email. You write it down, I'll give you a card. I would like you to email me and tell me what words, in your words, your experience, what do you think we should put on these questionnaires? Because I think we're asking the wrong questions, and that the pain scales that are available, especially the verbal ones, are made for more nociceptive pain and regular pain. We got to find out what is unique about your RSD, or because I hear this all the time. They're just saying, well, you've kicked up my RSD pain. Now, what does that mean? To me, that doesn't mean much, because I don't know what that means. I try to go, what do you mean by that? How is that different from hot pain, cold pain, sharp pain, whatever? There's something different. Trying to tell me what it is, so we can put this in some of our scales, and then we can tell when that's getting better. That's my whole point. My take-home message. We're done. Any questions? Other questions? Like I said, if you want the email address, I'll give you a card. If you just sometime drop me an email, anonymously, whatever, just say what you think it feels like. So we can somehow incorporate this, and we can ask the right questions. Thank you.
My answer to that is, what part do you want to know about?
All of it.
But they're different in different places.
Well, then tell me about all of them.
No, I mean, but when I'm asked that, here's the 10 things.
That's fine. When you're home, just let me know, because we want to improve on this. The only way we can help with treatments is we get a better idea of what's wrong. Okay, we assume certain things. We assume because we haven't had RSD, Bill and I never had it, we assume certain things.